17. Intestinal gas. Fernando Agebiras. Although many patients encountered in clinical practice complain about intestinal gas, systematic investigation of this subject did not begin until the 1960s, when studies by Michael Levitt, MD, and colleagues began to shed light on the pathophysiology of intestinal gas. 1. Composition and volume of gastrointestinal gas. The GI tract normally contains a relatively small amount of gas. The volume of gas within the intestinal lumen is determined by the balance between gas input and output, a highly dynamic process. Gas input may result from swallowing, chemical reactions, bacterial fermentation, and diffusion from the blood, whereas output involves belching, bacterial consumption, absorption into the blood, and anal evacuation. Despite this variety of factors, the volume of gas within the GI tract is remarkably constant and similar among healthy persons too, suggesting that it is under tight homeostatic control. Measurements of intestinal gas volume have been performed using a specifically designed CT technique. 2-4 Data acquisition is relatively simple, but analysis is fairly elaborate and has been carefully validated. This technique has confirmed previous measurements by other techniques showing about 100 to 200 ml of gas in the fasting state and somewhat larger volumes, 65% increase, after ingestion of a meal, Figs 17.1 and 17.2. Analysis of gas composition is technically challenging, and still only few and relatively old data are available. In a study of 10 healthy fasting subjects, the overall composition of gas within the GI tract was assessed using a washout technique in which a rapid infusion of argon into the jejunum via an intraluminal tube was used to flush out the intestinal gases. Gas effluent was collected via a rectal tube and analyzed. 5 gases N2, O2, CO2, H2, and methane, CH4, were found to account for more than 99% of intestinal gas. Many additional gases were present in trace concentrations. During fasting, N2 was usually predominant, O2 was 224 present in low concentrations, and the concentrations of CO2, H2, and CH4 were highly variable. The latter three gases are related to fermentation of meal residues and may predominate in the postprandial period, see later. Gas metabolism and excretion. GI gas is distributed in 3 compartments: stomach, small intestine, and colon. In each compartment the volume and composition of gas depend on gas metabolism and diffusion of gas between the lumen and blood. Part of the gas in one compartment is propelled to the next, and the end product is evacuated per anus. Fig 17.3 schematically depicts gas homeostasis in various segments of the GI tract. Diffusion of gas between the intestinal lumen and blood. The rate and direction of diffusion of each gas is a function of the diffusivity, partial pressure difference between lumen and blood, and exposure of the gas to the mucosal surface. The diffusivity of a gas across the mucosa of the GI tract depends on its solubility in water. For a given partial pressure difference, CO2 diffuses much more rapidly than H2, CH4, N2, and O2. Luminal gases with a partial pressure, concentration, higher than that in venous blood pass into the circulation and vice versa. Gas absorption also depends on the extent of the mucosal area and the time of exposure. H2 and CH4 absorbed from the bowel are not metabolized by the host and are excreted in expired air. Breath analysis provides a simple means of estimating the production of these gases in the GI tract. Breath excretion of these gases is the product of the alveolar ventilation rate and their alveolar concentrations. Because alveolar ventilation is relatively constant in sedentary conditions, the end alveolar breath concentration of H2 and CH4 can be used as a simple indicator of their total breath excretion. Mouth to stomach. The stomach normally contains a relatively small amount of gas, 10 to 20 ml. Point 2. Its location within the stomach is determined by flotation and gravitational forces. In the upright position, gas forms a bubble in the fundus of the stomach. By contrast, in the supine position, gas forms a thin film lining the anterior wall of the gastric corpus and antrum close to the abdominal wall, see Fig 17.1. Air swallowing, rather than intraluminal production, is believed to be the major source of stomach gas, as suggested by the absence of the gastric bubble in patients with advanced achalasia, see Chapter 44, but the normal amount of air swallowing is not clear. Gas leaves the stomach via belching, absorption, or emptying into the duodenum. The belching process has been well documented, but there is hardly any information related to the passage of gases across the gastric mucosa or the emptying of gas into the duodenum. Given the lower proportion of CO2 and a higher proportion of O2 in swallowed air compared with that in blood, in theory, CO2 should diffuse from blood into the stomach bubble and O2 from the lumen to blood. Because N2 diffuses poorly across the mucosa, luminal N2 throughout the GI tract presumably derives from swallowed air. Fig 17.1 CT image analysis of abdominal gas content, green, in a healthy subject in a supine position. An anterior view is shown on the left. Note in the lateral view, right, that in the supine position, most luminal gas is located close to the anterior abdominal wall. From Acarino A, Perez F, Agebiras F, ETAL intestinal gas and bloating, effect of prokinetic stimulation. AMJ Gastrointestinal 2008, 103:2036-42. Stomach small right trans left pelvic bowel verse Fig 17.2 abdominal gas volume in various segments of the GI tract in fasting and fed states as determined by CT volumetric analysis. The postprandial increment in intestinal gas is located predominantly in the pelvic portion of the colon. From Perez F, Acarino A, Agebiras F, ETAL gas distribution within the human gut, effect of meals. AMJ Gastrointestinal 2007, 102:842-9. Small intestine. From 10 to 20 ml of gas is normally present in the small intestine, usually in the form of small bubbles scattered along the intestinal lumen. 2,5 Radiologic images of intestinal air fluid levels in the erect position indicate that liquid is present below the gas bubble and is seen only with abnormal fluid retention, as in an ileus or obstruction. See chapters 123 and 124. Theoretically, in the upper small intestine, a large amount of CO2 is liberated from the interaction of bicarbonate and acid. However, studies using CT-based volumetric analysis did not detect changes in gas volume within the small bowel in the postprandial period. 2 The gas produced should diffuse into the blood, which is plausible for CO2, or be transported to the colon. An increase in colonic gas, although relatively small, is observed after a meal, see later. Gas production by small bowel microbiota is considered negligible in normal conditions, but direct evidence of this conclusion is lacking. Patients with intestinal obstruction or pseudo-obstruction, impaired motility, develop large amounts of gas within the small bowel, but the origin and mechanisms of this accumulation remain unclear. The colon normally contains around 50 to 100 ml of gas, see Fig 17.2.2,6a study comparing gas content based on CT images taken during fasting and 99 plus or minus 22 minutes after a meal showed an increase in gas in the pelvic colon, see Fig 17.2, earlier than would be expected for gas derived from colonic fermentation of food substrates. 2 Therefore, gas of proximal GI tract origin is presumably propelled into the colon after ingestion of a meal, possibly by a gastroileal reflex. However, colonic gas originates primarily by the metabolic activity of the microbiota and is eliminated by mucosal absorption, microbiota gas consumption, and anal evacuation. With the growing interest in intestinal microbiota, the study of intestinal gas production and evacuation has become particularly important because it reflects the metabolic activity of intestinal microbiota. Colonic endoluminal microenvironment and gas metabolism. The upper part of the digestive tract primarily has a nutritional function. Useful components, such as nutrients, water, and minerals, are extracted from ingested material by a process of digestion and absorption. Non-absorbed residues pass into the colon and serve as substrates for colonic microbiota, which carry out key functions related to host development and homeostasis. See Chapter 3. Therefore, the colon serves as a kind of marsupial pouch that provides the appropriate environment to host the largest proportion of the body's microbiota and thereby serves as a complex metabolic organ. The metabolism of fermentable meal residues by microbiota results in the release of a series of metabolites, including gases, that in turn serve as substrates for other subsets of microbiota. Therefore, the colon contains an active mass of living matter that consists of microbiota, meal residues, and secondary metabolic products in a dynamic chain of metabolic reactions. Studies have shown that the colon contains a biomass of 500 to 800 ml, depending on the residues of the diet, with a daily dynamic turnover of 100 to 200 ml, which is the volume of fecal output. Fig 17.4.6,7 Gas production increases as soon as fermentable residues enter the colon, and the activity declines gradually, lasting for hours as long as substrates remain available, so that the residue loads of consecutive meals contribute to gas production. Stomach. Fig 17.3 Mechanisms of entry and elimination of intestinal gases. Air is swallowed, 1, and a sizable fraction is eructated, 2. Some O2 in swallowed air diffuses into the gastric mucosa, 3. The reaction of acid and bicarbonate in the duodenum yields copious CO2, 4, which diffuses into the blood, 5, while N2 diffuses into the lumen, 6, down the gradient established by CO2 production. In the colon, gas-producing microorganisms ferment unabsorbed residues, 7, thereby releasing CO2, H2, and CH4, as well as a variety of trace gases, 8. A large proportion of H2 is consumed by other microorganisms to reduce sulfate to sulfide, CO2 to acetate, 9, and CO2 to CH4, 10, thereby reducing the net volume of gas derived from bacterial metabolism. N2 and O2 diffuse from the blood into the colonic lumen down a gradient created by gas production by bacteria, 11. Gas is ordinarily propelled down the GI tract and evacuated per anus. The net result of all of these processes determines the volume and composition of gas in the different GI N2, O2, CO2, H2, CH4, trace gases tract compartments. Fig 17.4 Independent representation of gaseous and non-gaseous components of colonic content on CT in a healthy subject. From Bendezu R.A., Mago M., Moncla C., ETAL colonic content, effect of diet, meals, and defecation. Neurogastroenteral Model 2017, 29, 2. Fig 17.5.8 Therefore, basal gas production during fasting depends on the content of the colon, which is derived from the diet on previous days. The volume of gas produced depends on the amount of unabsorbed, fermentable residues present in the diet, although knowledge about the specific foodstuffs and products in the diet that contribute to intestinal gas production is limited and largely empiric. Some colonic microorganisms consume intraluminal gases, H2, CO2, and O2, and this catabolism accounts for a proportion of intraluminal gas disposal. 3 types of microorganisms consume H2, acetogens, sulfate-reducing organisms, and methanogens. 9 Acetogens consume H2 and CO2 to synthesize short-chain fatty acids. Sulfate-reducing microorganisms use H2 to reduce sulfate to sulfide. Methanogens use H2 to reduce CO2 to CH4. 10 Only about 40% of adults have sufficient concentrations of methanogens to yield detectable breath CH4 concentrations. Methanogens oxidize H2 more rapidly than other H2-consuming microorganisms. The inability of some individuals to increase breath H2 excretion probably reflects extremely efficient consumption of H2 by methanogens rather than a failure to produce H2. The degree of methanogenesis has been reported to be high in persons with constipation. Proposed explanations for this association are that slow colonic transit in constipated persons enhances the proliferation of methanogens and, conversely, that CH4 slows intestinal transit. 9 Plasticity of microbiota and gas metabolism. The composition of the colonic microbiota, and therefore, the amount of gas produced on a given diet, varies considerably among individuals, depending on early environmental conditions as well as factors encountered later in life, such as diet and antibiotic exposures. 11 Even in the same individuals, dietary habits influence microbiota composition, whereas fiber-rich diets increase its diversity. diets low in fermentable residues induce the opposite effect. 12-14 One study showed that a 3-day diet rich in flatulogenic residues increased the relative abundance of methanogens in healthy subjects. 12 Chronic ingestion of high doses of an intestinally malabsorbed disaccharide, e.g., lactulose by patients with constipation or lactose by persons with intestinal lactase deficiency, results in diminished breath H2 excretion following a challenge dose of the same disaccharide. 15 This phenomenon may result from colonic proliferation of organisms such as Bifidobacterium species that ferment lactose or lactulose via non-H2 releasing pathways or of gas-consuming microorganisms. Similarly, oral administration of a galacto-oligosaccharide with prebiotic properties has been shown to increase the volume of gas produced within the intestine. The volume then declines to baseline over the subsequent 3 weeks of administration. 5 Conceivably, the initial increase in gas production is due to the fermentation of the prebiotic, and the subsequent decline is due to adaptation by the microbiota. Indeed, changes in the microbiota composition are detected by the end of the administration period. 16 Another study indicated that adaptation of microbiota to regular prebiotic consumption involves a shift in microbiota metabolism toward low gas producing pathways, with a non-significant upregulation of gas-consuming activity. 17 Odoriferous gases. None of the quantitatively important gases has an odor. The unpleasant odor of feces is due to gases present in trace quantities. The intensity of the noxious odor of flatus samples correlates with concentrations of hydrogen sulfide and methane thiol. 18 Odoriferous gases are difficult to study, among other reasons, because they pass across rubber or plastic membranes that are impermeable to other gases. For example, these gases diffuse from the intracolonic milieu into an intrarectal latex balloon inflated with air, and the air recovered by deflating the balloon has the characteristic odor of these gases. Anal evacuation. Intestinal gas that is not absorbed or metabolized is eliminated via anal evacuation. Therefore, anal gas evacuation is the net result of gas dynamics along the entire GI tract, but in fact, anal evacuation is by and large determined by colonic gas homeostasis. A Fig 17.5 Postprandial rectal gas collection. Gas evacuation increased with a high flatulogenic challenge meal but was similar in healthy subjects and in patients complaining of flatulence. Cumulative data, mean plus or minus SE, after a probe meal are shown. From Mani-chan C., Ek A., Varela E., ETAL Anal gas evacuation and colonic microbiota in patients with flatulence, effect of diet. Gut 2014, 63:4018. Study in 20 healthy subjects showed that on their normal diets, the rate of gas evacuation 6 hours after breakfast was about 40 ml/h. On a highly flatulogenic diet, the rate increased to around 120 ml/h after a high residue meal. See Fig 17.5.12. These data corroborate previous observations with different diets. The average number of anal gas evacuations by healthy subjects on their normal diets is roughly 10 during the day, with an upper limit of normal of about 20 a day. 12,16 The number of evacuations is 2 to 3 times higher on a highly flatulogenic diet. Neither age nor gender correlates significantly with the frequency of flatus. About 200 ml of N2 are evacuated per anus daily independently of the diet. The volume of O2 evacuated is much smaller and not influenced by diet. 1920 It is not clear to what extent N2 and O2 in flatus is derived from swallowed air or diffuses from blood. The volumes of H2, CO2, and CH4 excreted in flatus, in subjects with methanogenic flora, are highly variable and depend on fermentative activity in the colon. In the presence of fermentable residues in the colon, their volumes increase. Conversely, after a 48-hour liquid fiber-free diet, anal evacuation of H2, CO2, and CH4 is almost abolished. 20 Studies have measured the volume of endogenous gas produced within the intestine using a washout technique. High-rate infusion of labeled exogenous gas directly into the jejunum washes endogenous gas from the intestine and thereby prevents its absorption and consumption. 16,21 To determine the proportion of endogenous gas eliminated from the lumen, volumes of endogenous gas collected per anus in paired studies with and without gaseous washout have been compared. the volume of endogenous gas measured in the washout experiments approximates the total volume of gas produced, whereas gas evacuated through the anus in basal experiments, without washout, reflects the net excess of intraluminal elimination over gas production. These studies have consistently shown that a large proportion of the gas produced after a meal is rapidly eliminated from the intestinal lumen either by absorption into the blood and excretion by breath or by gas-consuming microorganisms, and only a modest proportion, about 20% to 25%, is eliminated per anus. However, the proportion of gas clearance by absorption versus consumption was not discriminated in these experiments. In a classic study, long-term simultaneous measurements of rectal and breath H2 excretion were performed in adult subjects maintained in an airtight environment 22 and the proportion of gas particularly H2, CO2, and CH4 removed from the colon via intestinal absorption and anal evacuation was found to depend on the rate of gas production. When H2 production was low, breath accounted for 65% of total H2 excretion, with 35% of H2 eliminated per anus. However, when H2 production was high, only 20% was eliminated via the breath, and the major part, 80%, was eliminated per anus. Because the intestinal absorption process for H2 is not saturatable, the decreasing proportion of H2 excreted in the breath is presumably a result of more rapid propulsion of the gas to the anus. Likewise, the concentration of CO2 in flatus tends to be highest during periods of high gas production and rapid anal evacuation. Intestinal propulsion, accommodation, and tolerance to gas. The aboral propulsion of gas in the intestine is a crucial determinant of the volume of gas present in each segment of the GI tract and the total volume in all segments at any moment. Gas transit determines the residence time of gas in the intestinal lumen. Absorption and bacterial consumption of gas are influenced by transit time, as is the composition of gas evacuated from the anus. Therefore, the increase in anal gas evacuation may be related in some conditions to increased intestinal gas propulsion, rather than to increased production. Gas movement along the intestine has been studied using experimental models of intestinal gas infusion, but it is not known how much gas moves from one compartment to the next in normal conditions. In contrast to the gastric cardia, which allows belching, the normal ileocecal valve is highly competent and does not allow ileal gas reflux even during experimental inflation of the colon. 23 Intestinal gas transit and tolerance have been measured using a gas challenge test in which a mixture of gases is continually infused into the jejunum and anal gas output is quantified. A dose-response study using infusion rates of up to 30 ml/min, 1.8 L/h, showed that most healthy subjects evacuate gas as rapidly as it is infused, with little or no discomfort. 24 Transit of gas, like that of solids and liquids, is modulated by a series of reflex mechanisms. Intraluminal nutrients, particularly lipids, delay gas transit. 25 Whereas mechanical stimulation of the intestine, e.g., mild rectal distension, has a strong prokinetic effect. 26 Gas is moved along the GI tract far more rapidly than solids and liquids, but the type of motor activity that determines gas transit is not known. Conceivably, movement and displacement of large masses of low-resistance gas is produced by subtle changes in tonic activity and capacitance of the intestine that do not affect the movement of solids and liquids. 27 This activity can be detected by a barostat 26,27 but not by conventional manometry. Gas boluses infused into the left colon have been shown to elicit forceful peristaltic contractions that precede small gas expulsions. 28 But this type of phasic event has not been recorded during continuous gas infusion with a barostat located inside the rectum. Therefore, these phasic events could be a response to focal distension produced by abrupt delivery of intraluminal gas. Gas transit is normally effective, but when an appreciable amount of gas is retained within the GI tract, subjects may develop abdominal distension and symptoms. Different experimental models of gas retention have been used to show that although abdominal distension is related to the volume of gas within the GI tract, perception of abdominal symptoms depends on both intestinal motor activity and the intraluminal distribution of gas. 29,30 Retention of gas in the intestine stimulates an abdominal accommodation reflex that adapts the muscular activity of the anterior abdominal wall and the diaphragm to the volume load. Considerable colonic gas retention produces relatively small increments in girth in healthy persons, because the anterior abdominal wall contracts and the diaphragm relaxes, thereby expanding the abdominal cavity in a cephalad direction. 31 The thorax participates in the accommodation reflex. Cephalad displacement of the diaphragm is associated with intercostal contraction and compensatory expansion of the costal wall to limit the impact on lung volume and function. 32 Therefore, this abdomino-phrenothoracic coordination limits the increase in abdominal girth that results from an increase in intestinal contents. Clinical gas problems. Patients frequently complain of a generic problem with gas, and the initial step for the clinician is to determine whether the patient is referring to chronic eructation, passage of excessive gas, odoriferous flatus or breath, impaired anal gas evacuation, or abdominal bloating and visible abdominal distension. Each of these complaints has a different pathophysiology and treatment. A specific questionnaire for the evaluation of gas-related symptoms has been developed. 33 Repetitive eructation pathophysiology. The occasional belch expels air from the stomach that has been swallowed with ingested solids or liquids. Repetitive eructation results from inadvertent and compulsive aspiration of air into the hypopharynx and esophagus, most of which is immediately expelled before reaching the stomach. 34 Aspiration of air into the esophagus may be produced by pharyngeal injection, thoracic suction, or both. 34-35 Breed-Neward and Smout have proposed the terms aerophagia, air swallowing, and gastric belching, venting air from the stomach, in contrast to supragastric belching, repetitive eructation of air aspirated into the esophagus, although it is unclear whether aspirated air can reach the stomach. Indeed, supragastric belching can elicit regurgitation of reflux episodes. 34-35 Repetitive eructation is frequently triggered by emotional stress. Episodes of continuous belching often occur after meals. In a proportion of cases, careful interrogation reveals underlying dyspeptic type postprandial symptoms that patients misinterpret as excessive gas in the stomach. If swallowed air enters the stomach, discomfort may increase. Eructation produces partial relief and reinforces the false impression of the patient, and a vicious cycle develops. Therefore, chronic eructation is almost always a behavioral disorder, and radiologic and endoscopic evaluation should be reserved for patients who have associated symptoms or signs suggestive of thoracic or abdominal pathology. It is not known why and how these patients learn this maneuver and acquire the habit. In some patients with aerophagia, swallowed air may pass into the intestine, and they may complain of a bloating sensation rather than excessive eructation. 34-36 Difficulty with eructation after a fundoplication for GERD results in the gas bloat syndrome. See Chapter 46. Treatment of repetitive eructation begins with providing a clear-cut pathophysiologic explanation for the patient's repetitive belching, that air swallowing rather than gas production in the GI tract is the problem. Distress is diminished by an understanding of the benign nature of chronic eructation. Patients should be instructed to refrain from belching. Holding a pencil between the teeth during episodes of repetitive belching may help a patient become aware of swallowing and stop the cycle. If present, underlying dyspeptic symptoms should also be treated. See Chapter 14. Only in severe refractory cases is a psychiatric consultation advisable. Flatulence pathophysiology. In a minority of persons, excess flatulence may be due to a condition that results in carbohydrate malabsorption, e.g., lactose malabsorption, celiac disease. A case of severe flatulence secondary to air swallowing has been reported 37, but this seems to be a rare occurrence. A study in 30 consecutive patients whose predominant complaint was excessive gas evacuation per anus showed that the subjective perception was not confirmed by objective measures in some of the patients, and that, despite their beliefs, the number of daytime gas evacuations measured with an event marker was within the normal range. 12 On the other hand, when specifically questioned, it became clear that flatulence was associated in most instances with other GI symptoms, particularly abdominal bloating. Interestingly, the volume of gas collected after a test meal in flatulent patients, in those with either a normal or excessive number of measured passages, was similar to that in healthy subjects. See Fig 17.5. It has been consistently shown that patients with functional GI symptoms have increased colonic and rectal perception, Visceral hypersensitivity, 1338, see Chapter 122. This finding could explain the lower tolerance for and more efficient evacuation of gas arriving into the rectum. 39 More frequent passages of smaller volumes could be a behavioral response to rectal gas sensation. The alternative possibility that gas is retained within the colon after a test meal was excluded by careful volumetric analysis of intestinal gas volume based on CT.12. Endogenous mucus may be a fermentable substrate. 40. This finding is the proposed explanation for the high fasting H2 excretion observed in SIBO, see Chapter 105, and untreated celiac disease, see Chapter 107. Treatment in patients with an identifiable condition that results in intestinal carbohydrate malabsorption, e.g., lactose malabsorption, celiac disease. Treatment of the underlying condition reduces gas production. In patients with functional flatulence, i.e., no demonstrable intestinal absorptive defect, gas production can be effectively reduced by a low flatulogenic diet. Reduction of gas production in these patients is associated with a dramatic improvement in subjective flatulence and abdominal symptoms, even though their basal gas production is within the normal range. Improvement is similar in patients with an excessive or normal number of gas evacuations on the patient's basal diet, suggesting that a bulking effect of the low flatulogenic diet may also be involved. 12 Despite many beliefs concerning which foods cause gas, scientific data concerning the effect of diet on anal gas evacuation are sparse. 41 Foods that provide minimal substrate to colonic bacteria include proteins, e.g., meat, fowl, fish, eggs, and certain carbohydrates, e.g., gluten-free bread. Rice bread. Foods thought to increase gas include legumes, Brussels sprouts, onions, celery, carrots, raisins, bananas, fermentable fiber, and complex starches like wheat and potatoes. Fruits and vegetables, particularly legumes, contain indigestible oligosaccharides like stachyose and raffinose that are readily fermented by colonic bacteria. 42 A pancreatic amylase inhibitor in beans slows starch digestion and absorption. 43 Fermentable fiber also provides substrate for gas production, although one study has shown that the standard dose of psyllium results in a minimal increase in H2 excretion. 44 Both fructose present in soft drinks and sorbitol, a low-calorie sugar substitute, may escape small bowel absorption, but their practical contribution to colonic gas production is uncertain. Selective restriction of specific foodstuffs, such as onion and garlic, may reduce odoriferous gases, but experimental evidence is lacking. In general, after a 1-week low flatulogenic diet, patients usually experience relief of symptoms. 45 By an orderly reintroduction of eliminated foodstuffs, patients may learn to identify the offending meal components. Diets low in fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, FODMAPs, have become popular. These diets are complex to design and cumbersome to follow and do not seem to offer documentable advantages over simpler low-residue alternatives. 40,46-49 Some data indicate that FODMAP restriction has deleterious effects on good intestinal microbiota. 50 And it is not known whether the same is true for other low-residue diets, see Chapter 122. Similarly, little experimental support is available to recommend a gluten-free diet in the absence of celiac disease or wheat intolerance, see Chapter 107. Commercial preparations of beta-galactosidase, e.g., Beano, are touted to enhance digestion of the indigestible oligosaccharides present in legumes and other vegetables. 51 But efficacy has only been demonstrated for the liquid preparation. Tablets containing this enzyme may not be effective. Simethicone has defoaming properties that eliminate bubbles that might trap gas. 52 But it does not reduce the volume of gas. Activated charcoal has been reported to reduce breath H2 excretion. 53 But another study showed that charcoal does not bind H2, or any other quantitatively important intestinal gas, and does not reduce breath H2 excretion. 54 Bismuth subsalicylate in high doses may reduce odoriferous flatus, but its use may not be justifiable because of its potential toxicity. 55 Several commercial devices, cushions, pads, underwear, use activated charcoal to adsorb odoriferous gases, Cushions have been shown to be less effective than pads or underwear. 56 Antibiotics, particularly rifaximin, have been claimed to reduce intestinal gas production. 57 But decreased rectal gas excretion has not been demonstrated. Given the problems associated with chronic antibiotic therapy as well as the lack of a clear-cut benefit, it seems inadvisable to use antibiotics to manipulate the microbiota of flatulent patients. Pre- and probiotics may influence the composition of colonic microbiota and thereby reduce anal gas evacuation. As discussed earlier, a galacto-oligosaccharide prebiotic induces adaptation of colonic microbiota so that gas-producing metabolism is reduced. 16,17 A study has shown that the benefit of this prebiotic administered for 4 weeks is similar to that of a low FODMAP diet. However, whereas the improvement persisted 2 weeks after termination of administration of the prebiotic, a rebound effect was observed after discontinuation of the low FODMAP diet. 58 Whether the benefit is specific to this galacto-oligosaccharide prebiotic is unknown. Impaired gas evacuation. In contrast to patients with excessive flatus, some patients complain of gas retention associated with impaired fecal evacuation. Normally, evacuation of gas results from a mild increase in intra-abdominal pressure coupled with anal relaxation. Incoordination of this process produces functional outlet obstruction that may be associated with the sensation of difficult gas evacuation and constipation. See Chapter 19. Fecal retention prolongs colonic fermentation and could increase gas production. Persons who complain of gas retention and impaired anal evacuation may benefit from biofeedback treatment, which can improve both gas and fecal evacuation and may also improve associated abdominal symptoms, particularly bloating. Abdominal bloating and distension pathophysiology. Symptoms commonly attributed to too much gas, e.g., abdominal bloating, distension, are among the most frequently encountered GI complaints. 59 Bloating refers to the sensation of increased abdominal pressure. Abdominal distension refers to an objective increase in abdominal girth. In fact, the term visible abdominal distension seems more accurate. Distension usually develops following meals or at the end of the day and resolves after an overnight rest. Measurements using inductance plethysmography and CT have objectively demonstrated a clear-cut increase in abdominal girth with episodes of bloating and distension. Fig 17.6.3,60-63 Some patients with IBS, particularly those with rectal hypersensitivity, complain of bloating in the absence of objective distension. See Chapter 122. 60 Patients with IBS who complain of frequent bloating have been reported to have increased gas production caused by SIBO or intestinal malabsorption. See Chapters 105 and 122. However, this finding has not been supported by other well-designed studies. 64,65 It has been shown that in patients complaining of bloating and abdominal distension, the net production of intestinal gas and the content of abdominal gas are similar to those in healthy subjects. 63,66 Excessive gas has been observed, however, in patients with severe motility disorders, such as chronic intestinal pseudo-obstruction. See Chapter 124. 67. These patients with intestinal neuropathy or myopathy are rare and usually seen in referral centers. Fig 17.7. Multiple studies using intestinal gas infusion have shown consistently that patients with bloating have impaired handling of the infused gas. In response to an exogenous gas load, these patients exhibit gas retention, abdominal symptoms, or both. 66,68-71 These abnormalities apparently reflect impaired reflex control of gas transit. 25,72-75 as well as the frequently demonstrated hypersensitivity to bowel distension in patients with IBS. 38 Therefore, gas transit studies seem to provide a sensitive method of identifying subtle intestinal motor disturbances that are not detectable by conventional diagnostic tests. Despite the disturbances in gas propulsion described earlier, no abnormalities in intestinal gas volume and distribution have been detected in relation to symptoms. 5,6 A series of studies of patients with IBS, in which abdominal CT images were compared under basal conditions and during an episode of visible distension, demonstrated that the sensation of distension is associated with an increase in the anteroposterior diameter of the abdomen and a significant diaphragmatic descent but only a modest increment in intestinal gas content. See Fig 17.6.63. Thorough analysis of intestinal gas distribution in a large cohort of patients failed to detect abnormalities, for example, localized basal distension. Fig 17.6. Mechanisms of functional abdominal distension. Upper panel, CT images in the same patient during basal conditions, no distension, and during an episode of abdominal distension. Lower panel, differences during distension versus basal conditions, n equals 47. Note the increase in anteroposterior, AP, abdominal diameter, red, increase in abdominal gas, blue, and diaphragmatic descent, green. All changes were statistically significant, asterisk. Adapted from Acarino A, Perez F, Agebiras F, ETAL. Abdominal distension results from caudoventral redistribution of contents. Gastroenterology 2009, 136:1544-51. Gas accumulations, in most patients with symptoms 5, likewise, no abnormalities in colonic biomass were detected. 6 Electromyographic studies have shown that the abdomen normally adapts to an increase in contents via a coordinated abdominophrenic response. 31 patients with IBS and bloating have an uncoordinated response, with paradoxical diaphragmatic contraction and anterior wall relaxation. 76,77 Whereas normal accommodation of abdominal contents seems to be a reflex response, some data suggest that abnormal accommodation in patients with distension is a behavioral response, because it can be reversed by biofeedback techniques. 63,78,79 The trigger for this conditioned response is not known, but it could be speculated that minor increases in bowel contents that are well tolerated by healthy subjects induce a sensation of bloating in hypersensitive patients and trigger the conditioned somatic response that leads to visible abdominal distension. Treatment. Because patients with bloating and abdominal distension seem to have a common variant of IBS, the basic approach to treatment should be similar to that for IBS, see Chapter 122. Non-pharmacologic therapies. Intestinal clearance of perfused gas is increased by mild exercise and the erect posture, which may explain anecdotal observations that activity, as opposed to resting in the supine posture, improves bloating in some patients. 80-82 Although intestinal gas volumes appear to be normal in patients with bloating, the sensitivity of their intestines to normal volumes of bowel contents suggests that limiting gas production to a minimum may be beneficial. Therefore, dietary manipulations to reduce gas production, described earlier, may be beneficial. Treatment of constipation reduces bulking and improves bloating. Some data indicate that the use of probiotics may reduce symptoms of IBS, particularly abdominal bloating and distension. 83,84 Results with probiotic agents are variable and depend on the bacterial species used, dose, duration of treatment, and endpoints used for evaluation. Hypnosis has been reported to reduce symptoms of IBS, including bloating. 85 Patients with visible abdominal distension can be Fig 17.7 Tridimensional reconstruction of CT images in a healthy subject and a patient with intestinal dysmotility. Note that in the patient with intestinal dysmotility, there is large pooling of gas, in blue, particularly in the small bowel, as compared with the healthy subject. From Barba E., Quiroga S., Acarino A., ETAL. Mechanisms of abdominal distension in severe intestinal dysmotility, abdominothoracic response to gut retention. Neurogastroenteral Model 2013, 25 E389-94. Healthy subject patient trained to correct the activity of the diaphragm and the anterior abdominal wall using biofeedback techniques. 21, 26 Pharmacologic therapies. Although studies have suggested that antibiotics, particularly rifaximin, can reduce symptoms of IBS. 57 IBS may first appear after antibiotic therapy. 79 The effectiveness of rifaximin in the treatment of gas symptoms remains controversial. Neostigmine, a potent prokinetic agent, has been reported to reduce abdominal symptoms resulting from an intestinal infusion of gas. 69 Chronic administration of pyridostigmine improves symptoms in patients complaining of bloating but has only marginal effects on intestinal gas content. 4 Other prokinetic agents may also be effective. Inhibition of intestinal motor activity enhances gas tolerance. 30 A meta-analysis of the efficacy of smooth muscle relaxants in the treatment of IBS has concluded that these drugs are superior to placebo in the management of symptoms, specifically abdominal pain and distension. 86 Peppermint oil has an antispasmodic effect on the GI tract because of the calcium channel blocker activity of its active constituent, menthol, but its benefit in IBS is questionable. 87 Drugs with antinociceptive action may also be useful, see Chapter 122. Pneumatosis cystoides intestinalis. Pneumatosis cystoides intestinalis and coli is a condition characterized by the presence of gas-filled cysts in the wall of the small bowel, colon, or both, see Chapter 128. The cysts may be asymptomatic or associated with diarrhea, bloating, or abdominal pain. 88,89 Pneumatosis cystoides has been reported as a complication of connective tissue diseases. 90 Many patients with pneumatosis have extremely high breath H2 concentrations, a finding indicative of high luminal concentrations of H2. 91,92 The feces of 3 patients with pneumatosis of the colon were found to have unusually low concentrations of H2 consuming organisms. Therefore, the high luminal H2 of these subjects appears to reflect H2 production that is relatively unopposed by H2 consumption. An association between pneumatosis and chronic administration of alpha-glucosidase inhibitors has been reported. 89 How a high luminal H2 tension results in pneumatosis is controversial. One proposal is that small intramural gas collections normally occur with some frequency but are quickly absorbed into the circulation. In the presence of high H2 production, rapid diffusion of luminal H2 into the cyst dilutes other cyst gases, e.g., N2. Therefore, the cyst N2 tension remains lower than or equal to that in the blood. As a result, N2 in the cyst cannot be absorbed and the cyst persists. The most effective treatment to eliminate the cysts is administration of high concentrations of O2 via inhalation. This maneuver reduces the blood N2 tension to a value below that of the cyst, allowing N2 to diffuse from the cyst into the blood, with resolution of the cyst. Other forms of therapy that may be effective are heliox, a low-density gas mixture, antibiotics that inhibit H2 production. Ciprofloxacin has been used successfully in a patient with SIBO and pneumatosis cystoides intestinalis, and dietary manipulations like lactose restriction that reduce the delivery of fermentable substrate to colonic bacteria. Full references for this chapter can be found on vexpertconsult.com.